outside of the revenue cycle management world. I would like to personally welcome you into our RCM chat room where we discuss all things revenue cycle management. Now, when I say all things revenue cycle management, I mean everything from the front end of the revenue cycle, including patient access or pre-op issues. And of course, I tackle the mid-revenue cycle where we focus on all things coding and charge capture, which has been my passion for over 20 years now. And of course, we would never leave out the back end of our rev cycle where we highlight information geared towards the billing process, everything from claim submission all the way to denials management. If you work on any part of the physician revenue cycle, then this podcast is for you. So sit back and relax as we dive into today's discussion. By way of introduction, my name is Latrice Freeman Baker, and I will be your host for today's chat. What will we be talking about today? Well, as you know, the 2025 CMS physician fee schedule has dropped, and so we want to give you some information on the highlights of some of the most impactful changes from the CMS 2025 Final Rule. Now, again, as you know, on November 1st, CMS released its final rule fact sheet, and it highlighted some of the major changes coming in 2025 for services rendered to Medicare beneficiaries. Now, since some of these changes will have a significant impact to our provider services and to our physician practices, we really want to take some time to give you an overview of those changes. Now, if you're looking for the final rule and trying to figure out where it is, the final rule is actually not scheduled to be officially published until December 9th. However, you can download the pre-published version so that you can get a jump start on reviewing some of the things that's coming in the final rule. This is important because, as you know, the final rule is over 3,000 pages, and you really want to have some time to peruse some of the rules, especially those that are applicable to your healthcare setting. So if you haven't done so already, download those two documents. Download the CMS final rule fact sheet, and then use that in conjunction with the actual final rule so you can get a jump start on knowing what's coming up for 2025, especially for those who are billing for Medicare and for those payers who may follow Medicare. Now, the way I'm going to tackle this information is that I've divided it up into three categories. We're going to talk about the good of the final rule. We're going to move on to the bad, and you know where I'm going with this, right? We're going to also talk about the ugly. Now, to be fair, and for all intents and purposes, I'm dividing it up into these categories not to reflect CMS's intention or intent when publishing the rule. I'm really dividing it up into the categories of the good, the bad, and the ugly, just to kind of show you the level of impact or the implications, whether positive or negative, on many physician practices and healthcare organizations. And so again, this is my levels for the impact. You may think something differently, but let me show you why I feel this way. Why don't we start off on the good foot, I'll say. So let's start with the what I think is a very positive change, and that is the payment expansion for G2211. Now, I know some of you guys were kicking and screaming this year about G2211 because you were afraid that some of your providers would abuse and misuse it. In fact, I've heard from some healthcare organizations that they won't even allow their providers to use it at all. And I get it because it was some of the requirements and that were published were a little vague and left a lot of room for misuse if the provider didn't understand the guidelines clearly. And so I get why we were afraid to allow our providers to use it. But, you know, organizations like the one that I work at, we did allow the use of G2211 because in some cases and in many cases it was warranted. And so for those who may not know, G2211 represented that outpatient or office E&M visit complexity where a provider was the focal point for all medical services pretty much for a patient's single complex condition. So in 2024, we began billing that code. But one of the complications we noticed, at least at the healthcare organizations that I've worked along with this year, is that many of the providers were a little concerned that if they qualified for G2211, right? So they had that base code, the base E&M code, office or outpatient E&M code, and they were the focal point. But then in a visit, they happened to ask the patient if they weren't, if they wanted a flu shot, let's say, or some other vaccine administration. Because they offered or provided the vaccine administration, they had to put modifier 25 on that base E&M code. Now we know what happens with G2211 if modifier 25 is anywhere on that claim, right? That means you're prohibited from billing G2211, and they felt that was a little unfair. And in this case, I'm very happy that Medicare or CMS listened to some of these concerns and the logic behind it. And so beginning January the 1st, 2025, CMS would expand that payment of G2211 to allow billing when an office or outpatient E&M base code, we already talked about this, right? 99202 to 99205 or 99212 to 99215. When that code is billed by the same practitioner on the same day as an annual wellness visit, vaccine administration, or any other Medicare Part B preventive service, when that's furnished in the office or outpatient setting, even though the E&M still requires that modifier 25, Medicare will allow payment for G2211. But again, I want to emphasize it's only for vaccine administration, annual wellness visits, and that includes the IPPE visit or the Welcome to Medicare visit, as well as any other Medicare Part B preventive service. So I think that's a good move. It surely will calm some of my providers down who work in a primary care setting. And so I'm hoping to see that, this have a positive impact on our practices. All right, so that was an old code for last year. Let's talk about some of these new codes that popped up in the final rule. In fact, Medicare has added a number of G codes to the 2025 fee schedule. So I want to just talk about some of the highlights. Now, since we're already talking about visit complexity, I thought I'll highlight a new one, another visit complexity code, but this one is in the setting of inpatient or observation care and only in the context of a patient who has a confirmed or suspected infectious disease. I'm talking about HCPCS code G0545 here. Now, G0545 has been added again to account for that intensity and the complexity that's inherent to some of these hospital inpatient and observation services. But again, it has to be associated with a patient who has a confirmed or suspected infectious disease. One other thing I want to highlight about this code, it has to be performed by an MD or an NPP with specialized training in infectious disease. Now that's going to be a beast to try to manage because we don't always know this, the scope of practice, for example, for some of our NPPs or their training, and whether, it may be easier to know if our doctors have a taxonomy or a specialty code for infectious disease. But I do want to make sure we point that out. This is only used when performed by an MD or NPP that has specialized training in infectious diseases. Now, this new code, again, is being implemented to address, kind of that unique elements that's associated with managing an infectious disease, such as, for instance, control risk for the patients and even their close contacts. And these close contacts can include like our nurses that's on the unit. But it also addresses the unique challenges in diagnosing some of these infectious diseases, especially as it relates to individual resistant patterns of these pathogens. So I want to highlight that code as a possibility for your practices and for your hospital this year. Let's move into three interesting code sets that all are all in the context of behavioral health or mental health services. One of the code sets I wanted to talk about was HCPCS G0546 through G0551, and these are behavioral health interprofessional console codes. Now, this new code set is similar to our existing interprofessional console codes. The difference is that the new codes will be limited to, and I'm quoting here, a practitioner in a specialty whose covered services are limited by statute to services for the diagnosis of mental illness. So now the behavioral health world has their own interprofessional console codes that they will be using. One thing to note about these is that the treating practitioner will be required to obtain patients' consent in advance of these services, and that consent must be documented in the patient's record. Now, in addition to these consent requirements, all of other consultation requirements will have to be met. Like we know that, right? Like the three R's: the documentation of the requesting provider, the rendering of the service, and of course the report back to the requesting. So those are going to be some interesting codes. I think they're going to be very beneficial for those who have psych services in their practices. Another code under the behavioral health or mental health realm that I want to talk about is G0560. Now, that's for safety planning interventions. So, CMS, in their continued effort to address mental health treatment access, they've added G0560 to report safety planning interventions each 20 minutes that's personally performed by the billing provider. So this code should be billed or could be billed along with an E&M code. It could be billed along with psychotherapy. And it's again to report safety planning interventions for patients' risk of harm to themselves. So think about our patients that may have suicidal ideations with a plan or harm to others. And so this kind of helps compensate for some of the resources that it takes to address these concerns with our patients. Now, the other code I want to mention is the CMS added is G0544. Now, this is a post-discharge telephonic follow-up contact code, and it's to be used in conjunction with a discharge from the emergency department for behavioral health crisis or another crisis encounter. Again, this code can only be billed monthly for follow-up care after this patient's time for treatment for a mental health crisis. So again, another solid code, I think, to address some of the mental health crises and managing those that we're seeing in our practices. All right. One last code that I thought I'd talk about because people are already asking about it, and that's for code set G0556 through G0558. Now, this is for Advanced Primary Care Management Services, and you'll see a lot of people just calls it APCM. Now, CMS has added these new APCM codes to recognize the resources involved in furnishing services in an advanced primary care delivery model. Now, these codes will be paid to only one provider per patient per month. Again, one provider per patient per month. And this provider is also required to obtain a patient consent for these services. CMS is really working to make sure patients don't get kind of these surprise bills about services that they think is just part of normal care and not understand that it may incur a cost. So again, patient consent will be required. Now, the interesting thing is instead of tracking time for these care management codes like we see with some of the other care management codes like TCM and CCM, CMS has instead developed three different levels or tiers to differentiate each code. Our level one code, which will be G0556, will be used for patients with one chronic condition. Level 2, G0557, this is for a patient who has two or more chronic conditions. And then, of course, just to keep us on our toes, they gave us a level 3 code, G0558, for patients with two or more chronic conditions and is a qualified Medicare beneficiary. So these are some of the good things that's coming our way. Now, I want to address the what's going on in some of your heads about it's good on one hand, but it also impacts other services. As you know, Medicare has to operate on a budget neutral system, which means that when they have new services come aboard, that payment for those services to cover those services is usually taken from another service. And so not that another service is eliminated, but what they paid for that service in the past may change or decrease because now they have to have enough funds to pay for the new code. I call it the rob Peter to pay Paul system, but what can you do? It's the system we live with today. But at least they're addressing some of the things that are missing in our healthcare system. All right, let's move on to the next category, the bad. Now, again, just to be fair to CMS, they warned us about this. We knew that the conversion factor will be reduced and changed, but I want to make sure practices are budgeting for this conversion factor reduction. So beginning January, you're going to see a 2.83% reduction in the physician fee schedule payment rates. That means that in the new year, the payment conversion factor will be decreased from $33.29 down to $32.35 for the new year. Now, many practices are already operating on tight budgets within small margins. So this hit, though it may seem small to some, will have further impact on these types of practices, especially when it comes to hiring more staff, or maybe they're trying to obtain and upgrade equipment. The list can go on. So it may seem like small chump change, but this will have a significant impact. The other thing I always like to remind those who are responsible for budgets, or those who are responsible for doing business plans for new hires, or for new services, that make sure you update your formulas, because when you're calculating projected reimbursement for next year for Medicare, you want to make sure that you're getting that right. All right. So that was the bad. I only have one on the list. I really, really hate to go into the ugly, but we got to talk about it, right? So let's talk about the ugly. And again, this is something that CMS has warned us about. They've told us it was coming. And so I just want to highlight it here because I think it's going to have more impact that people realize. And that's the rolling back of reimbursement for telemedicine services. Now, I'm going to start by saying we still have a chance here. But unless Congress intervenes, beginning January 1st, 2025, the pre-pandemic geographic restrictions that were in place for Medicare telehealth services will retake effect for most of those services. Now, what does that mean? That means that Medicare telehealth services will once again, in general, be available only to beneficiaries who are in rural or a healthcare shortage area, and only when those patients are located in certain types of medical settings. And there will be very few exceptions to this rule. Therefore, think about it. We will be unable to bill Medicare for such services, telemedicine services, unless we meet those geographic location restriction criteria. That's huge, especially if you live in a metropolitan area like I do. I live in Chicago, and to be honest, we have become accustomed to and used to um, performing telehealth services. The patients have become accustomed and used to being able to log on to a video chat to get their services done and not drive and come into the office. So this not only change to the reimbursement, but the mentality and trying to reel our patients back in to come in for inpatient services is going to be huge, and it's going to take some time to adjust. I remember just a month ago, my boss was like, oh yeah, they're thinking about making us come into the office to work for 3 days, and my first reaction was like, say what now? And that's because I've become used to working from home, right? And so that's going to be a mental change when patients are told that now, unless they pay themselves, that they would have to make an in-person, face-to-face visit appointment with the practices. And so we're going to be watching and trying to help our providers manage this a little bit and our patients manage this a little bit. But I think this is going to uh, be a huge change. Again, all those services that we've been allowed to provide to patients through audio and video telemedicine platforms, they'll have to be arranged by scheduling the patient for an in-office face-to-face visit. So we'll have to watch that. And I know some of you guys are thinking that, oh, I already saw some of the codes that's released by CPT, so I think we'll be okay because of these new telemedicine codes. So first of all, yes, the AMA has in its 2025 release established these new codes to better describe telemedicine E&M codes. However, CMS is already on it. They addressed that. Unfortunately, Medicare has stated that they will not pay separately for these new CPT codes. The only code that will be recognized and reimbursed from that code set is CPT code 98016, which is that virtual check-in code. And keep in mind that it's not that they're reimbursing for an additional code. They're simply swapping 98016 out for that G2012 code because it describes the same service. The other thing, since we're talking about the CPT changes, which we'll get more information in a couple of weeks from the CPT symposium, I don't know if you realize, but the telephone E&M service codes, they've been deleted, CPT 99441 through 99443. And again, it's because AMA has kind of put together these new codes, but unfortunately, Medicare has stated that they're not paying for these codes. So, what about the question of whether you should continue to build telehealth to your commercial payers? Because we're talking about Medicare, right? Here. Now, that question of whether you should continue to build to your commercial payers is certainly a question that your leadership team should start considering sooner rather than later. But one thing I want you to keep in mind is that in 2024, many of those commercial payers began rolling back payment for many of the telehealth services anyway, or the services we consider telehealth. For example, many already stopped paying or reimbursing for non-audio and visual E&M codes, such as those telephone E&M visits that we talked about being deleted from the CPT code book, as well as the online digital E&M codes. So they've already started looking at, hey, we're rolling back some of these services, and that happened this year. Another thing to keep in mind is that oftentimes commercial payers adopt and begin to follow Medicare's leads on some of these reimbursement policies. So, there's a chance that they're going to see that Medicare is doing away with telehealth or payment for telehealth, and they may follow suit. In the end, I guess we'll just have to simply wait and see how these payers respond. We also still need to wait and see how if Congress steps in to address some of these CMS telehealth policies as a whole. If they step in to stop the reduction in the conversion factor, we just have to wait. I know the bill has been on their desk since September, mid-September, and we're just waiting to see if they step in so some of these things that we've been allowed to do since the pandemic could continue. So we'll see. I really wish that I could do a deeper dive into other changes like the new cardio risk assessment codes for atherosclerotic disease or the updates that's coming to caregiver training codes, but I simply have run out of time for today. But really, really want to thank you guys for joining me on this journey as we go through the final rule. Okay, my friends, that about wraps it up for today. Thank you for joining us for our chat. We really, really appreciate you joining us in the RCM chat room. You are welcome back anytime, and we hope to see you again soon. Bye-bye now.